A very good afternoon. I speak to Dr. Dennis and my fellow friends. My name is Kaisan, and today our group member and I will present on our topic physical activity and asthma. First, I will introduce my group member who are Muhammad Adnan bin Muhammad Azlam, Muhammad Yusri Aiman bin Abdurrahman, Muhammad Azrin bin Amri, and Puteri Nurul Atira binti Bantira. So first, I will give an introduction to physical activity and asthma. Asthma is a heterogeneous chronic inflammatory disease of the airways that is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and intensity, together with variable expiratory airflow limitation. In the present era, asthma is estimated to affect as many as 339 million people across all ages worldwide, carries a substantial burden of morbidity and mortality, and constitutes a major source of global economic burden in terms of both direct and indirect costs. WHO defines physical activity as any bodily movement produced by skeletal muscles that requires energy expenditure. Physical activity refers to all movement including during leisure time, for transport to get to and from places, or as part of a person's work. Both moderate and vigorous intensity physical activity improve health. Physical activity often provokes asthma-related symptoms reflecting the natural or insufficient control of asthma. Thus, asthmatic patients may often intuitively or purposely avoid exercise and adopt a sedentary lifestyle. Not long ago, asthmatic patients were in fact regarded as chronically infirm individuals who needed to be sheltered and avoid physical exertion in order to prevent severe asthma attacks. However, advances in understanding of the pathobiology and the management of the disease, including the development of a wide range of potent drugs and effective delivery devices, avoidance of triggering factors, patient education, and asthma action plans have induced a paradigm shift in the perception of asthmatic patients and the therapeutic goals. In the modern era, the ultimate goals of asthma management include the minimization of symptoms so that patients can maintain normal levels of activity and achieve good quality of life. Accordingly, the Global Initiative for Asthma, GINA, recommends people with asthma to engage in regular physical activity in order to improve their general health. Increasing physical activity may be an important overlooked link in optimizing the management of asthma, especially the severe type of asthma and specific asthmatic populations. Accumulating evidence links enhanced physical activity with favorable outcomes, including better overall asthma control, less exacerbations, and lower healthcare use. Therefore, physical activity in asthma warrants attention and focus. The presentation today presents the current recommendations for physical activity, discusses the available evidence on physical activity in asthma, and examines the causes of low physical activity in adult asthmatic patients. It also reviews the effect of daily physical activity and exercise training on the pathology and clinical outcomes of asthma. Finally, it summarizes the evidence on interventions targeting physical activity in asthma. Next, I will talk about how does asthma impact physical activity. During an asthma attack, inflammation and spasm of the lining of the airway wall causes the bronchioles in the lungs to narrow. Asthma patients will experience wheezing, shortness of breath, and difficulty exercising. As the muscle spasm, the airways narrow and it blocking from breathing. Therefore, the lung will experience a lack of air. As a result, the patient may faint. Patients with problem exercise induction bronchospasm, narrowing of the airways normally occurs 8 minutes to 15 minutes of physical activity. This of physical condition can last for 60 minutes. Hence, a qualified and experienced trainer can help to design an exercise program that is just right and seek expert help before exercise training or start doing physical activity. The next one is asthma and obesity. Obesity has been linked to other comorbidities that have been shown to worsen asthma. The role of obesity in asthma is primarily thought of in two distinct phenotypes, which is early onset allergic asthma that is complicated by obesity, and later onset non-allergic asthma in which obesity is implicated. The increased incidence of asthma in obese individuals suggests that obesity contributes to the onset of asthma. However, the mechanisms are not clear. The lower lung volumes result in smooth muscle remodeling and airway hyperactivity. Other mechanisms proposed in the effect of obesity on asthma include an increase in systematic inflammatory mediators associated with obesity. Leptin is a hormone secreted by adipocytes, and its level is proportional to the amount of adipose tissue in an individual. Genetic factors have also been linked to both obesity and asthma, and may play a role in co-occurrence of these two diseases. The interaction between asthma and obesity is complex and multifactorial. Many of the factors discussed above, such as inflammatory markers or impaired lung physiology, are affected by lifestyle factors, such as diet and level of physical activity. Lifestyle interventions work to target both obesity and asthma independently and as comorbid conditions.
Next is exercise-induced asthma. The term exercise-induced asthma, EIA, and exercise-induced bronchoconstriction, EIB, are often used interchangeably to describe symptoms of asthma such as cough, wheeze, or dyspnea provoked by vigorous physical activity. EIA can be defined as symptoms of asthma occurring after heavy exercise, whereas EIB denote the reduction in lungs function occurring after exercise, as seen in the standardized exercise test. A minimum of 5 to 8 minutes continuous high-intensity effort is required to develop an exercise-induced bronchoconstrictive response. EIB is usually observed 2 to 10 minutes after heavy exercise and not during maximum exercise intensity. EIA and EIB have a high prevalence also in elite athletes, especially within endurance type of sports such as running, swimming, and cycling in the winter sports. This is because long duration exercise and very low air temperature easily expose these athletes to the osmolar and vascular change in the airway. Fundamental in the EIA or EIB photopsychology. Why do elite athletes develop asthma? It is mainly because of the respiratory epithelial damage and reduced repair to contribute to the development of inflammation in the athlete asthma phenotype. Photopsychological background. Photogenic mechanism of EIA or EIB probably differ in the athlete compared to children, adolescent, or adult with asthma. Exercise is a quantifiable and reproducible stressor that can be modified experimentally and can be considered as a model of stress. It has an effect of the endocrine activity and the nervous of the immune system, thereby activity several complex interacting mechanisms within the psycho-neuroimmune endocrine pathways. Classical mechanisms behind EIA and EIB include the so-called osmolar and vascular hypothesis. Both hypotheses are based on the marked increased ventilation during physical activity, leading to increases water and heat loss through respiration. There are few tips to help prevent EIA that I will be sharing. First, make sure that your asthma is being well managed, as this will make exercise-induced asthma less likely to occur. Second, always carry your reliever medicine and spacer with you, and if written on your asthma action plan, take your reliever medicine up to 50 minutes before warming up. It is important to warm up before exercise as usual. Next, during exercise, watch for asthma symptoms and stop and take your reliever medicine if symptoms appear. Only return to exercise if your asthma symptoms have been relieved. If asthma symptoms appear for a second time during exercise, take your reliever medicine again until symptoms have been relieved. It is not recommended that you return to the activity. Last but not least, after exercise, cool down as usual. Asthma symptoms can occur up to half an hour after exercise. Make sure you take your reliever medicine if you have symptoms after exercise.
Next is ways to minimize the impact of asthma on physical activity. Firstly, reduce strenuous physical activities that require a lot of energy consumption, such as running, playing futsal, playing badminton, and others, because all of these activities will increase the risk of having an asthma attack more seriously. Secondly, warm up before physical activity and cool down after physical activity. Asthma patients are encouraged to carry an inhaler during physical activity and use them 15 minutes before physical activity. Lastly, avoid doing activities until out of breath and avoid high intensity activities. Next is examples of recommended exercise for asthmatic patients. From a physiological scope, exercise training evidently improves cardiopulmonary fitness, whereas its impact on lung function is less clear. The improvement in cardiopulmonary fitness is important because it may reduce the risk of dyspnea due to deconditioning and other conditions unrelated to airflow limitation that may mistakenly attribute to asthma. This essentially enables legal breathing reserve for activities of daily life with a better effort-benefit ratio. Secondly is swimming. Swimming is often recommended as a form of exercise for asthmatic due to the humidified and warm air, low pollen count exposure, and hydrostatic pressure on the thoracic wall, although some concern is about chlorine exposure with indoor pools. Thirdly, exercise training at high altitude. The impact of exercise training at high altitude have also been investigated in asthmatic population. High altitude treatment have long been recommended and applied as beneficial in asthma due to lower allergen exposure, less air pollution, and lower air humidity. The increased air density at altitude also reduces heavy resistance, which might increase exercise capacity. Comprehensive rehabilitation program with endurance training was highly effective in improving asthma control in patients with poorly controlled asthma. And lastly is exercise.
My first point is regular aerobic exercise with muscle training and stretching improves asthma control measured by a broad spectrum of indicators, including the reduction in use of rescue asthma medication. It is proven that those who were diagnosed with asthma may have an easier time to control the common system of asthma than people who rely on drugs if they regularly do the aerobic exercise, while it seems to have little effect on PEF variability. Physical activity gives benefit in cardiorespiratory fitness for asthmatic patients that refers to the ability of the circulatory and respiratory system. Cardiorespiratory fitness is a strong predictor of morbidity and mortality, as moderate high cardiorespiratory fitness reduces many of heart hazard associated with obesity and asthma in adults. The primary measures of cardiorespiratory fitness is VO2 max. CRF or cardiorespiratory fitness measures how asthmatic patients' body is able to transport and utilize oxygen during any sustained physical activity. Good CRF is not only important for asthmatic patients' overall health and quality of life, such as energy levels, sleep, and mood, but also reduce the risk of heart disease, diabetes, and stroke. Exercise. My third point is exercise training affect asthmatic patients as it improves asthma control. Lung function slightly increase in favor of exercise training. The bronchial tube becomes swollen and thick. During exercise, two of the important organs of the body come into action, the heart and the lungs. The lungs bring oxygen into the body to provide energy and remove carbon dioxide, the waste product created when you produce energy. When we exercise, the muscle work harder and the body use more oxygen and produce more carbon dioxide. Our circulation also speed up to take the oxygen to the muscles so they can keep moving. When our lungs are healthy, we keep a large breathing reserve. We may feel out of breath after exercise, but will not be short of breath. When we reduce lung function, we may use a large part of your breathing reserve. This may make you feel out of breath, which can be an unpleasant feeling. This can be dangerous for asthmatic person as the opening of the bronchial tube becomes smaller and the air passage becomes narrower. This condition leads to difficulty in breathing and cause breathlessness. The fourth, physical training programs have been designed for patients with asthma with the aim of improving physical fitness, neuromuscular coordination, and self-confidence. When people feel better physically, they will feel better mentally as they will have more energy to take on challenges and overcome obstacles. Regular exercise makes the body stronger and lowers the risk for asthma disease worsen and getting serious. It also helps to reduce stress, depression, and anxiety. When we have physical strength, we often gain mental strength. Regular exercise helps build confidence by improving our body image. While exercising, we are more likely to strengthen and tone our body, and seeing these results can greatly improve our self-esteem and help us feel better about the way we look. When people feel better physically, they will feel better mentally as they will have more energy to take on challenges and overcome obstacles. The last one, asthma inflames the airways as it causes red, swollen bronchial tubes in the lungs. This kind of inflammation can damage the lungs. People with inflammation problem may have symptoms like a coughing, especially at night or in the morning, wheezing, which they may make a whistling sound when breathing, shortness of breath, tightness pain, or pressure in the chest, and trouble of sleeping because of the breathing problems. Chemicals from asthmatic person body's white blood cell enter the blood or tissues to protect body from invaders. This raises the blood flow to the area of injury or infection. It causes redness and warmth. Some of the chemicals cause fluid to leak into the tissue, resulting in swelling. This protective process may trigger nerves and cause pain. Higher numbers of white blood cells and the things they make joints cause irritation, swelling of the joint lining, and loss of cartilage over time. Treating this is the key to manage asthma in the long run. So, doing some regular exercise can actually decrease the inflammation. It was by reducing inflammatory proteins, which improves how the airways respond to exercise.
Intervention in targeting physical activity in asthma. The first intervention is combining exercise training and diet weight loss intervention. This is because individuals with obese have reduced responsiveness to inhaled corticosteroid and increases the risk for developing asthma as well as the severity of asthma. Obesity and asthma are associated diseases, and obesity-related asthma is considered a distinct asthma phenotype. The next intervention is behavioral intervention. Behavior modification is important when increasing physical activity in daily life. In modifying one's behavior, discipline have important role, especially in doing physical activity in daily life and choosing a healthier option in diet. Several techniques that can be used in modifying one's behavior is by individual goal setting and behavior contract. Secondly is monitoring and feedback. Thirdly, avoidance strategy, and lastly, a problem-solving coping planning. These techniques have been proven to be effective in behavior modification.
This is a flow chart which illustrates the consequences of asthma in physical activity and vice versa. Firstly, when an individual have asthma system, EIB, obesity and the others, their participation in physical activity will be significantly reduced. This will negatively affect asthma control, lung function and exercise capacity. In contrast, when this individual increase their physical activity in daily life by doing exercise training, losing weight and other inventions, this will provide numerous benefits in asthma in the ways that it will improve their asthma control, reduce healthcare use and reduce airways inflammation or BHR.
I will take over from here. The next intervention is through pharmacological intervention. The first therapy would be using anti-interleukin 5 therapy for eosinophilic phenotype of severe asthma. Eosinophilic asthma is marked by high levels of white blood cells called eosinophils, which fight infections and attack invading bacteria. This therapy enables reduction of asthma exacerbations and steroid use, better control of asthma and health-related quality of life, and improved lung function. Mepolizumab and raclizumab have been shown to reduce severe asthma exacerbations, improve forced expiratory volume, and allow oral corticosteroid reduction in severe asthmatics with persisting airway eosinophilia. Benralizumab enhances antibody-dependent cell-mediated cytotoxicity of both basophils and eosinophils alongside improving asthma control of lung function and is compared with placebo in severe eosinophilic asthma. The second treatment is anti-interleukin 4 and interleukin 13. IL-4 and IL-13 are type 2 cytokines that have a variety of effects, including immunoglobulin class switching for the production of IgE, enhanced airway smooth muscle contractility, eosinophil recruitment, and airway mucus production. Lebrikizumab and tralokinumab have been demonstrated to improve lung function and possibly reduce asthma exacerbations. However, these two are still under evaluations. The third treatment is tiotropium, which is a long-acting anti-muscarinic bronchodilator used in the management of chronic obstructive pulmonary disorder and asthma. Tiotropium acts mainly on M3 muscarinic receptors located in the airways to produce smooth muscle relaxation and bronchodilation. And last but not least is bronchial thermoplasty, aka BT, is a medical procedure that some people with severe asthma can have to help open their airways. Over time, severe asthma causes the smooth muscle tissue lining the airways to thicken. Therefore, BT is a heat treatment that reduces the amount of thickened smooth muscle on the inside walls of the airways. Lastly, we have come to the end of our presentation. To conclude this presentation, I will sum things up and recall certain important points from previous discussion. As we all are aware of, there are many types of asthma. So the first step is to see a doctor or an allergist when you suffer the symptoms of asthma. Getting diagnosed for the type of asthma is recommended so that we could identify the cause and how to treat or prevent it. Subjects with asthma have a unique response to physical activity. On one hand, exercise can provoke an increase in airways resistance, leading to exercise-induced asthma. On the other, regular physical activity and participation in sports are considered to be useful in the management of asthma, especially in children and adolescents, though this has not been investigated in the same detail as the mechanisms of exercise-induced asthma. However, having asthma need not prevent a patient from obtaining the benefits of increased physical activity. People with asthma who take regular exercise can improve their cardiorespiratory fitness and work capacity. Moreover, the results of available published evidence indicate that high physical activity levels are a possible protective factor against asthma development, but further studies are necessary to determine if regular exercise reduces symptoms and improves the quality of life in asthma. As we have discussed earlier, there are many interventions that could be practiced in targeting physical activity in asthma. Asthmatic patients can start making small changes in their behavior, diets, and physical activity in daily life so that they don't feel burdened by making dramatic changes that are unsustainable. So, what should be done concerning exercise-induced asthma and exercise-induced bronchoconstriction? Firstly, athletes have to understand how EIA and EIB is developed, as my friend Adnan has explained earlier. It's important for asthmatic athletes to avoid strenuous exercise during temporarily increased exposure to biological stress, such as increased aeroallergen load, extreme cold air environment, or strenuous exercise too close to a recent viral respiratory tract infection. With an early and precise diagnosis, insightful precaution protecting the airways from extreme biological stress, and an early start of anti-inflammatory treatment, the progression of bronchial hyperresponsiveness and asthma in these athletes may usually be well controlled. Asthmatic athletes should not worry, as data from the recent Olympic Games show that asthmatic athletes have won more medals during the Games more than athletes without asthma, demonstrating beyond doubt that the asthmatic athletes may compete on an equal level with their peers. Therefore, our presentation have come to an end here.